Most people believe that if a surgeon recommends an operation, it must be the right decision. The doctor went to medical school for a decade. The hospital has a reputation. The surgery has been performed thousands of times. Who are you to question it? That trust is understandable, and in many cases, it is warranted. But I have stood at the operating table for over 20 years, and I have seen the other side of that trust. I have seen procedures performed on patients over 60 that had a low probability of benefit and a high probability of serious harm. I have seen families give consent because they did not know what questions to ask. I have seen patients wake up from surgery worse than when they went in, and sometimes not wake up at all. There are 5 surgical procedures that, in my experience and in the published evidence, are recommended to seniors far more often than the risk-to-benefit ratio justifies. Procedures where the conversation before the operating room frequently does not include the full picture. I am not telling you to refuse surgery. I am telling you to ask better questions before you agree to it. My name is Dr. Emmanuel Osei. I'm a cardiovascular surgeon with over 2 decades in the operating room. And today I'm going to show you the 5 surgeries I would urge every senior to think very carefully about before agreeing, and exactly what to ask your surgeon first. Stay with me. This may be the most important conversation about surgery you have ever had. Before I give you the list, I need you to understand something fundamental about how surgical risk works after 60, because the numbers your surgeon quotes may not tell the whole story. When a surgeon tells you a procedure has a 2% mortality rate, that number comes from studies conducted across all age groups. It includes 40-year-olds with no underlying conditions. It includes 55-year-olds in excellent health. For a 72-year-old with hypertension, diabetes, and reduced kidney function, that 2% can become 8, 10, or 15%. The general statistic is not your statistic. After 60, 3 things change the surgical equation dramatically. Your heart and lungs have less reserve. They can handle the stress of anesthesia and surgery, but the margin is smaller. Any complication pushes you closer to the edge faster. Your kidneys clear anesthesia drugs and post-surgical medications more slowly. This increases the risk of delirium, prolonged sedation, and kidney injury after major procedures. And your immune system recovers more slowly from surgical trauma. Wound healing takes longer. Infection risk is higher. And the inflammatory response triggered by surgery, which in younger patients resolves in days, can persist for weeks in older adults. This is why a procedure that carries acceptable risk at 55 may carry genuinely dangerous risk at 70. And why the question is never just, can I survive this surgery? The question is, will this surgery leave me better off than I am right now? With that foundation, here are the 5 surgeries to question carefully. The first is spinal fusion surgery for back pain. Back pain is one of the most common complaints in people over 60, and spinal fusion, a procedure that permanently connects 2 or more vertebrae, is one of the most frequently performed spinal surgeries in the United States. Here is what the evidence shows. For the most common indication, degenerative disc disease without neurological compromise, multiple large randomized controlled trials have found that spinal fusion produces outcomes no better than intensive physical rehabilitation over a 12-month period. The surgery costs more, carries procedural risks, and in the long term, does not outperform the non-surgical alternative. Adjacent segment disease is an additional concern specific to older patients. When vertebrae are fused, the segments above and below carry more load. In a younger spine with good bone density and strong surrounding muscle, this compensation is manageable. In an older spine with osteoporosis and reduced muscle mass, adjacent segments often begin to degenerate within 2 to 5 years, sometimes requiring additional surgery. The procedural risks in older adults include blood clots, infection, hardware failure, and a particularly significant risk of post-surgical delirium from prolonged anesthesia. What to ask your surgeon? Have I tried a structured 12-week intensive physical rehabilitation program with a specialist? What is the specific nerve compression or instability that makes surgery the better option for my case? What are the adjacent segment disease risks given my bone density? If your spine surgeon cannot give you a clear, specific answer to why surgery outperforms rehabilitation in your particular case, that is important information. The second is open heart surgery for aortic valve replacement in very high-risk patients. Aortic stenosis, the narrowing of the heart valve that controls blood flow out of the heart, is common in older adults and can become severe enough to require intervention. I want to be absolutely clear. In many patients, aortic valve intervention is life-saving and should not be delayed. The question is, which intervention? Traditional open heart surgery for aortic valve replacement, involves stopping the heart, opening the chest, and operating on the heart directly. In patients over 75 with significant frailty, reduced heart function, or multiple comorbidities, the surgical mortality for open heart valve replacement can be substantial. TAVR, transcatheter aortic valve replacement, is a catheter-based procedure that replaces the valve without opening the chest. Multiple major trials have shown that TAVR produces equivalent or superior outcomes to open surgery in intermediate and high-risk patients, with significantly lower procedural mortality and shorter recovery. Yet some centers and some surgeons continue to recommend open surgery for patients who would be better served by TAVR, sometimes because of surgical volume incentives, sometimes because the center does not offer TAVR, sometimes simply because the open approach is what the surgeon trained on. What to ask your cardiologist and surgeon. Have I been formally assessed for TAVR eligibility? What is my STS risk score, the standardized surgical risk score? And what does that score indicate about my procedural risk for open surgery versus TAVR? I want to see both options discussed before I decide. The third is aggressive cancer surgery in frail, elderly patients. Cancer diagnosis creates enormous psychological pressure to do something immediately, and surgery, removal of the tumor, feels like the most definitive action possible. But here is the clinical reality that oncologists and surgeons do not always communicate clearly. In elderly patients with significant frailty, defined clinically as reduced physical reserve, unintentional weight loss, low grip strength, slow walking speed, and exhaustion, aggressive surgical resection of certain cancers carries perioperative mortality rates that may equal or exceed the survival benefit of the surgery itself. A frail 80-year-old with a newly diagnosed colon cancer may face a 15% chance of dying from the surgery, against a tumor that, if managed with less aggressive approaches, might take 3 to 5 years to become life-threatening. The surgery intended to extend life may shorten it. Frailty assessment before cancer surgery is an evidence-based standard of care. Not every center performs it. Not every surgeon orders it. What to ask before cancer surgery? Has a formal frailty assessment been performed? What is the estimated surgical mortality for a patient with my fitness level? What are the non-surgical management options and their likely outcomes? Is watchful waiting with palliative management a reasonable alternative given my overall health? These are not defeatist questions. They are the questions that allow you to make an informed decision about what kind of treatment aligns with what you value for your remaining years. The fourth is carotid endarterectomy for asymptomatic stenosis. Carotid endarterectomy is a surgical procedure to clear plaque from the carotid arteries, the vessels supplying blood to the brain. When it is performed in patients who have already had a TIA or stroke, the evidence strongly supports its benefit. The controversy is in asymptomatic patients, people who have carotid stenosis discovered incidentally, with no neurological symptoms. Multiple major trials, including ACST and ACAS, have shown that the benefit of carotid endarterectomy in asymptomatic patients is modest at best. The absolute risk reduction in stroke is approximately 1% per year. The procedural stroke and death rate for the surgery itself is approximately 2 to 3% in real-world settings. This means that in asymptomatic patients, the surgery carries a higher short-term risk of causing a stroke than the annual risk of stroke it is meant to prevent. Medical management, optimized blood pressure control, statin therapy, antiplatelet medication, has improved dramatically since these trials were conducted. Current evidence suggests that well-managed medical therapy may produce outcomes equivalent to surgery in asymptomatic carotid stenosis without the procedural risk. What to ask your vascular surgeon? Have I had any neurological symptoms, even transient, that make this a symptomatic rather than asymptomatic case? What is the center's documented procedural stroke and death rate for this operation? Have we optimized medical management before considering surgery? The fifth is knee replacement surgery in patients with significant cardiovascular or metabolic disease. Knee replacement is among the most commonly performed elective surgeries in people over 60. For many patients, it produces dramatic improvements in pain and mobility. I am not questioning its value in appropriate candidates. The concern is in patients with poorly controlled heart failure, recent cardiac events, severe obesity, or uncontrolled diabetes, conditions that significantly elevate the risk of surgical complications. Postoperative complications of knee replacement in high-risk older patients include deep vein thrombosis, pulmonary embolism, surgical site infection, cardiac events triggered by the stress of surgery, and periprosthetic joint infection, which can require additional surgeries and prolonged antibiotic treatment. In patients with severe obesity, implant failure rates are higher. In patients with uncontrolled diabetes, wound healing is compromised and infection rates are elevated. In patients with heart failure, the fluid shifts of major surgery can precipitate acute decompensation. The appropriate question before elective knee replacement is not just whether you will benefit, but whether your cardiovascular and metabolic conditions are optimized first. What to ask your orthopedic surgeon? Has my cardiologist cleared me specifically for this surgery? Have my diabetes and weight been optimized to reduce my complication risk? What is the infection rate at this center for patients with my health profile? I want to tell you about a man I'll call Joseph, 74 years old, retired school principal. He had been experiencing back pain for 2 years, significant, limiting, affecting his sleep. An MRI showed multi-level degenerative disc disease. His orthopedic surgeon recommended spinal fusion at 2 levels. Joseph's daughter, who happened to be a physical therapist, asked one question before the surgery was scheduled. Has he tried a structured rehabilitation program specifically designed for spinal stenosis? The surgeon acknowledged that he had not. Joseph was referred to a spine rehabilitation specialist. 12 weeks of targeted physical therapy, core strengthening, and aquatic therapy. At the end of 12 weeks, Joseph's pain had reduced by 70%. He was sleeping through the night. He was walking 2 miles a day. He never had the surgery. He told me something 6 months later that I think about often. He said, "I was 3 weeks away from agreeing to have my spine fused. My daughter asked one question. One question changed everything. One question. That is the difference between an operation and a recovery." I want to say something directly before we close. Surgeons are not the enemy. The vast majority of surgeons I know are skilled, dedicated professionals who genuinely want the best outcomes for their patients. But surgery is a business. Operating rooms have costs. Surgical volumes affect hospital revenue. And the incentive structure of medicine does not always align perfectly with the question of whether this particular patient, at this particular age, with this particular set of conditions, will genuinely be better off after this particular operation. You are the only person in that equation who has no financial interest in the outcome of your surgery. You have only one interest, your health and your quality of life. Ask the questions, get a second opinion, understand your personal risk, not the population average, and never agree to an elective procedure without a clear, specific answer to the question, will this surgery leave me better than I am right now? Let me bring this together. 1. Spinal fusion for back pain. Ask whether structured rehabilitation has been tried and failed before surgery is considered. 2. Open heart valve replacement in high-risk seniors. Ask whether TAVR is an option and what your STS risk score indicates. 3. Aggressive cancer surgery in frail patients. Ask for a formal frailty assessment and a discussion of non-surgical alternatives. 4. Carotid endarterectomy for asymptomatic stenosis. Ask about the center's procedural stroke rate and whether optimized medical management is a comparable alternative. 5. Knee replacement in patients with uncontrolled cardiovascular or metabolic disease. Ask whether your underlying conditions are optimized before proceeding. One question at every surgical consultation. Will this surgery leave me better off than I am right now? And what is the evidence for that, specifically for a patient with my age and health profile? I want to hear from you. Have you or someone you love been recommended one of these surgeries? Did you ask questions before agreeing? And what happened? Tell me in the comments. I read every single one. And your experience might be exactly what someone else needs to hear before they sign a consent form. If this video gave you something important, share it. Not for me. For someone in your life who is facing a surgical recommendation and does not know what questions to ask. Send this to them. It could change everything. Everything I've shared today is based on current cardiovascular research, published surgical outcomes data, and my clinical experience as a cardiovascular surgeon. This is general information, not personal medical advice. Every surgical situation is unique. Never refuse or delay a surgery your doctor has recommended without first having a thorough conversation with your medical team. Some surgeries are urgently necessary, and the risks of delay are severe. Always consult your physician before making any decisions about your surgical care. Take care of your heart. It has been working for you every single minute of your life, without ever asking for anything in return.